Yeah, thank you very much. This has been an interesting year for nasopharynx cancer at this ASCO meeting. And as you know, this is a rare disease in North America, but very common in other parts of the world. Important to remember that there are 3 phase 3 trials combining immunotherapeutic agents, all PD-1 inhibitors, none of which included nivolumab or Pembrolizumab, which are the most commonly used PD-1 inhibitors here in this part of the world and worldwide as well. But these studies were all positive in terms of improving progression-free survival. What we saw at this ASCO is updates from the Jupiter 2 trial, which is a study using Toripalimab in combination with the sequencing of gemcitabine cisplatin followed by Toripalimab followed by maintenance Toripalimab, and that basically confirmed the improvement in overall survival that we saw a signal of earlier on. I think there are several questions in this disease that deserve to be looked at. Foremost is what are reliable biomarkers for looking at biomarkers that correlate with improved outcome, and those have not really been very well solidified in nasopharynx cancer. And so, for example, some early studies showed that PD-L1 expression could be correlated, but then the more mature trials, including the Jupiter updates in this meeting, did not really end up showing a correlation with PD-L1. And so we clearly need better biomarkers in terms of predicting outcome. The other factor is that single-agent immunotherapeutic agents have not really been very successful in this disease. If you look at the single-agent activity of early studies, you see responses of about 20 to 30% with single-agent Nivo and Pembro. When you look at newer generations PD-1 inhibitors, you may see a more generous response, up to 30 to 40% in some instances. Of course, all these are small trials. They're not really definitive studies. It's clear, however, that when you compare the single-agent immunotherapy with chemotherapy, that there's not a strong signal in favor of immunotherapy, unlike what we saw in non-nasopharynx cancers. And so, for example, the KEYNOTE-122 was a negative trial and did not really show any benefit to Pembrolizumab as a single agent. And part of the reason is the fact that this disease is probably more chemosensitive, so the control arm really overperformed of what we saw, for example, on the Checkmate 141 or the KEYNOTE-040. And so there is certainly a value of keeping chemotherapy in any mixture when we basically consider treatment of recurrent metastatic nasopharynx cancer, which is what these trials are showing us. Last but not least, I think it's important to keep remembering that all these PD-1 inhibitors are not really created necessarily equal. They have different mechanisms of action. Their binding site is different. Their recruitment of T cells and immunomodulatory factors may be completely different. Of course, preclinical data is suggesting this. But by the same token, we cannot really just rely on preclinical data. We really need clinical trials to confirm activity of these agents. The take-home message at the end is we should probably avoid substituting these agents for one another, because there's no clear evidence that the same activity will happen using any PD-1 inhibitor.